Hey there, good afternoon, everyone. My name is Cynthia Klein, and on behalf of our full Take Heart team, we'd like to welcome you to today's training event. We are very glad you joined us today. Today's session is intended to help you with building and implementing a successful automatic cardiac rehab referral system. We'll be joined by two very knowledgeable speakers today, Dr. Amy Miller and also Kathy Lee Bishop. Let me go ahead and go to the next slide. So today's presentation is fifth in a series of 10, so we've made it to the halfway mark. And it's 10 modules that are designed to provide implementation support and share best practices with Take Heart hospitals that are implementing automatic referral with care coordination. So as a reminder, all of our Take Heart training modules are guided by the Million Hearts Cardiac Rehab Change Package. And you can find this change package located in the Resource Center of the Take Heart website. Also a reminder, the Take Heart website also has all of the educational materials and resources and the training session recordings as well. So the format of our training sessions today, for those who haven't joined us previously, we have a subject matter expert presentation. We really want to make sure that we are using the chat and the polling features during the discussion and allowing some of that peer-to-peer sharing. After the session, hospitals will receive written guidance materials to reinforce and supplement the material that was presented today, and then technical assistance sessions will follow next week in the form of the peer action groups that partner hospitals participate in. So partner hospitals will attend the peer action groups, meet with their assigned coach, discuss the concepts that were presented today, and also provide updates on their progress, successes, challenges. The peer action groups also offer the hospitals the opportunity to offer support to other hospitals as well. And please remember that at any time you can reach out to your coaches between meetings for questions or concerns that you may have. On the next slide, also just as a reminder, we think folks remember this, but just as a reminder, you can claim the CEU credit for attending this session live. So there'll be a follow-up with additional information for that. So just a reminder there. And then last, before we get started, again, we are really interested in using the chat and the polling features. You know, we're not intending for this to be a purely didactic session. We'd like it to involve some chat and discussion with your peers. In order to do that, if you haven't done that before, you can ask a question or make a comment in the chat box. The big thing that we ask for is just make sure, and maybe go ahead and do it right now, just make sure to set your field to everyone so that everyone can see your question as we respond to it. That way, hopefully we can get a good discussion going here on today's session. All right, well, welcome again for joining us, and thank you for joining us today. Let me pass you next to Steve Hines, who's gonna start telling you a little bit about where we've been and where we're going today. Steve?
All right, excellent. Thank you very much, Cynthia, and welcome to everyone that's on the call today. This is the fifth of the 10 modules that we are working through as part of the Take Heart initiative. And just kind of to provide a little bit of context, as we look back in modules 1 and 2, which we combined, we talked about the importance of creating a multidisciplinary team with a strong cardiac rehab champion that will help to coordinate and really lead the planning and push the project forward. And by now, the team should have that, each partner hospital should have that team working and should have an aim statement, and have been creating and developing various elements of an action plan as you move along. In module 3, we focused on workflow processes because automatic referral and care coordination really involve substantive changes to your workflow processes. So we wanted to make sure that you understood what those workflow processes are before you could think about really changing them and making them work better for your program and for your patients. So care coordination, process mapping, that was the focus of module 3. And then the last module, which we had less than a month ago, focused on the critical issue of data, because data is foundational to automatic referral and effective care coordination. And it's data that enables you to identify patients that are eligible for cardiac rehab and it's data that enables you to see which of those patients are being referred, which of them are continuing, which of them are succeeding and graduating from your CR program, and where the gaps are so that you can address weaknesses and make things better for your patients. So those are the 4 foundational modules that we've addressed so far, and now we're ready to leap. And the leap that we're taking today is the major leap of focusing on automatic referral. But modules 5 through 10 all focus on how to change your workflow processes to integrate automatic referral and to enhance your care coordination so that you can achieve those better results for your patients and for your program. So that's where we are today. And just to make sure that we're starting with a shared understanding of what we mean by a completed referral. It's good to have an automatic referral system that identifies each eligible patient for CR and automatically refers them. That's good, but I think that we would also note, based on the literature, that automatic referral is not nearly as good as when you have automatic referral plus the referring cardiologist having a conversation with the patient about why they've been referred and the importance of them participating in cardiac rehab. And then we'd also say, and this is also based on the literature, but if you can extend beyond that to get the referral, to get the cardiologist conversation to promote cardiac rehab, and then to get the patient actually enrolled in your cardiac rehab program or the cardiac rehab program in which they're the most likely to be successful, that's even better. So that's what we're talking about when we talk about a completed referral. And what we want you to see is that it's not automatic referral or care coordination. Really, the best outcomes come when you have automatic referral plus effective care coordination. And getting to that point is where our focus is for today. Now, as far as our specific learning goals for today, we want you to understand why implementing automatic referral benefits patients in your program and why automatic referral makes care coordination critical. We also want to make sure that you understand how to design and work with and collaborate with your IT department to develop the EMR specs and implement the EMR specs for your automatic referral system. One of the things that I think you'll see from our speakers today is that that's going to be a slightly different process depending on your EMR, depending on your overall system, and we want you to understand how it works so that you can make it work for you most effectively. And then it's really important before you jump too far into automatic referral to make sure that it works right. So we want to talk to you about the first phases of testing today. Now, if you can get all of that done in the next 2 months, if COVID not permitting, we go around and shake your hand, because that would be a great accomplishment. So when we return to automatic referral in 2 modules, we'll continue the process there, picking up with testing and talking about actual implementation and training staff and working with cardiologists as you fully implement your automatic referral system. So that's where we are. We've asked people that are from participating hospitals which EMR they actually use, and you can see the results on this slide with similar numbers using both Cerner and Epic, and a smaller number which tend to be slightly smaller hospitals using Meditech. And our 2 panelists today represent systems that use both Cerner and Epic. So we'll give you a balanced distribution, and we'll say more about support for each of those 3 EMRs later on towards the end of the session today. I'm really delighted to introduce today's presenters, and we've had great conversations with them as we've worked to prepare for today. Amy Miller is an MD and a PhD, and she's the Associate CMIO for Massachusetts General Brigham Healthcare. She's worked as a part of the team that's implemented cardiac referral within the context of Epic. And then Kathy Lee Bishop is an exceptionally well-qualified person, a board-certified cardiovascular and pulmonary clinical specialist, the program manager at Emory St. Joseph's Hospital's cardiac rehabilitation program. She has played a pivotal role in implementing cardiac referral in a system that uses Cerner. So great speakers today. I'm looking forward to the conversation. I really want to encourage you to enter any questions or comments that you have in the chat as we go through the slides today. And so having said that, let me turn it over to Amy to get us started.
Thank you, Steve, and I want to welcome everyone today. As Steve said, to be successful, there are kind of two pillars that you need, right? So the automatic referral and care coordination. Today, we're going to be focusing exclusively on the automatic referral. Care coordination is going to be addressed in a future module. So when we say automatic referral, what exactly do we mean by that? So we want these to be things that are truly built into the workflow, so that unless the provider does something to opt out, the order is going to happen. It's not, I'm trying to get the provider to do it, but rather I'm putting it in the workflow so much that it magically happens unless the provider says, oh my God, no, I don't want this, let me remove it. So this way, you know, the goal is that the system identifies all the patients who qualify. It makes sure they don't have some contravening factor that would make them inappropriate for it, puts that order into the things that the provider is already doing, so that it truly is an automatic, frictionless experience for the provider to place the order. Kathy Lee, do you want to tell us a little bit about Emory and your experience with automatic referrals?
Sure. Good afternoon. Thank you, everyone, for attending. We're a large healthcare system in the South. We have 8 different hospitals. Some are academic teaching and some are community-based hospitals. We also have 25 ambulatory cardiovascular facilities that are spread out in the region. So our process really started with a review from the quality metrics of our cardiology division, get with the guidelines, looking at the action in the PCI registry. And we really wanted a better way of, you know, tracking, are we really referring to cardiac rehab? And at that time, all those hospitals had a different process. It wasn't standardized. A lot of it was paper driven, and we had no way of drilling down to the actual details. So it was at that time when we started this process, which is about 5 years ago, we had less than 20% of our patients were being referred for cardiac rehab. And so we had a target, and it was a really great place to start. We also had a wonderful physician champion who brought all the players together and then had us really work well with developing action plans and making us, you know, stay accountable to this. And not only what was our purpose, but what was it going to benefit and who was it going to benefit was really helpful to our process to remember, especially when we got in the weeds and the details and the challenges, just stepping back and saying, why are we doing this? What is our process? What is our outcome? And what's going to be our endpoint? And that was really helpful, you know, with our overall team.
That's great. Thank you. In terms of our organizational background at Mass General Brigham, so we have 2 academic medical centers, about 5 community hospitals. We were asked by one of the academic medical centers to look into options. Initially, the focus was really on ambulatory referrals. And as we kind of looked at technical options, we found that we could do a much better job on the technical side of helping automate on the inpatient side. And in fact, we're going to focus today on inpatient, because that does seem to be, so far for the programs that have done this, an easier place to focus and to have success. We do have some ambulatory alerting present in our system, but nothing that I would call true automation. We've had the inpatient automation up for a couple of years. It has been, we think, pretty successful, due, as Kathy Lee referred to, in large part to kind of multidisciplinary collaboration with the clinical side and the IT side working together to figure out what would work and then implementing it.
And Amy, I'll just add to that, if you don't mind. You know, one of the statements on this, or bullet point on this slide, was key advice for peers just starting out. Just remember, it's got to be fluid. There were things that happened in the past 2 years that we didn't expect. One of the neighboring healthcare systems opted not to have Kaiser Permanente as part of their system. Kaiser Permanente came to us, and so it was kind of starting all over again with the education, the process, not really understanding how Kaiser process. So don't get so fixated that it's done. Realize that you have to be able to be flexible and evolve as things come up that you didn't expect.
Absolutely. I think this past year has taught us all about how things will continue to come up that we don't expect. So I think that in, I believe it was module 3, you all kind of mapped out your current workflow processes and had some discussion about barriers that you run into. So the whole idea that we need automatic referrals implies that without an automatic referral, we're stumbling over some things. So some of the challenge are things like beliefs that maybe cardiac rehab isn't beneficial. Maybe this patient wouldn't go anyway, so why should I bother sending an order because it's just going to be a waste of time. Maybe it's someone else's job, right? Do I know this patient really qualifies? What are the exclusion criteria? Are they appropriate? And concerns about when is the right time. Is now the right time or should I wait? So all of those things are kind of opportunities for us to not act, to not place the referral. And those are the things that the automatic referral is really designed to protect you from and keep you from stumbling over those obstacles. So, sorry, go ahead.
I just think that was feedback, Amy.
Okay, excellent. So in terms of the belief that cardiac rehab may not be beneficial, the referrals really allow us to look at the evidence, build the referrals in an evidence-based fashion, and then there's nothing to stand in the way of that delivery. Our own kind of personal biases and beliefs don't trip us up. In the same way, the thought that this patient in front of me might not bother to come, we don't prejudge the patient. The system gives everyone the opportunity to be referred and to get the benefit of cardiac rehab. In terms of the uncertainty about when or how, we really make it consistent. So it's the same timing, same mechanism for everyone. It takes the decision about whose job is it out of the clinician's hand and puts it into the system so that the referral is always placed. Although, as I said, the provider has the opportunity to say, no, in my clinical judgment, this patient isn't appropriate and I'm going to opt them out. And it takes into account all of what our ideas of inclusion exclusion criteria are based on the available information available to us in the EMR, and we can program that in so that it is all taken appropriately into consideration.
And Amy, one of the things we did with that was when we met with our stakeholders and they said, but there are patients that even though they meet the criteria that I feel as a physician shouldn't be. And so what we did is we got a consensus of what those top diagnoses were to allow that physician to have that freedom if something came up and, God forbid that they have they have a PCI and have end stage cancer at the same time that they didn't know. And so we wanted to give something so the physicians felt that they weren't so restricted, but had some decision-making as part of it too.
Thank you, Kathy Lee. So in terms of thinking about the various patient populations, the easiest situation in terms of things that we can control are when it's our patients and it's our system, right? But that's certainly not always the case. Sometimes you're using a different EMR. Sometimes it's not your patients, it's patients from another location. So as we have more things that move out of our control, things get a little bit more complicated. We're going to be focusing today on eligible patients at your hospital in your system. So those internal kind of things. Now, those can be referred to external cardiac rehab programs, but we're going to be focusing primarily on the yellow box because it is quite frankly the easiest case. If we think about kind of the different implementation strategies based on those, as I said, the yellow is the easiest. That's where Take Heart focuses. As you kind of branch out to other patient populations, other EMRs, things get more complicated from the technical side, as well as kind of the care coordination and clinical side. And then when you go to external programs, there are some financial considerations in terms of are you talking about leakage and lack of revenue capture that can make things very challenging. And I will, I'm going to mute for a second to turn off the treadmill, just a sec. You go to the next slide. So as we said, for appropriate referrals, you need not just the automatic referral, but also that care coordination. So there has to be a human touch. And that will be a focus of a future module. Now when you're thinking of, sorry, someone trying to say something. Okay, so when you're thinking about how you're going to implement this, keep in mind that in general, your EMR is already live, right? So you are trying to do something into an existing information systems ecosystem, and those ecosystems are not created equally. And so is it easiest to do this as you admit the patient or as you discharge the patient? That actually is going to vary from institution to institution. So this really needs to be an early conversation between IT and clinical cardiology to come to a shared understanding of how this will work best at your facility in your existing system, and kind of use that as your starting point. Kathy Lee, do you want to talk to us a little bit about some of your insights on this?
Sure. So one of the challenge we had was we made assumptions as a healthcare system that we were all using the same order sets at every single hospital by every cardiologist and cardiothoracic surgeon. And so one of the things we had to do was gather that information, and we realized we were making an assumption, and it really wasn't true that everyone was following the same standardized practice when it comes to referring for cardiac rehab. And so one of the things we had to do was get all those hospitals and whoever would own, quote unquote, that order set, to the table with us to say, what is best practice and what is best for our patients, where it doesn't really impact the overall or make additional work on the workflow. And to me, that's part of the buy-in of what's the purpose of doing the automatic referral, who does it benefit, and what's that outcome. And so once everyone understood that, they didn't feel, like some of the community hospitals didn't feel like we were, stepping on their toes, or the, academic teaching centers didn't feel like we were putting something additional. Because one of the challenges with the academic teaching center is the floor staff changed every month. And so, they'd be like, oh, what do I have to do now? Why is this popping up? This didn't happen on the other floor. And so some of the challenges of this, and I like that this is cyclical, is that you do have to keep moving on it. It's just got to keep evolving. And, it's, when I look at our community hospitals, they deliver great care to our patients, and we were just asking them to even go another level. And same thing with the academic side. And so once everyone realized what the best was for the patient, we were all on board.
That's great, and I totally agree. It is always an evolving process, but once you get everyone on board, it can be an incredibly rewarding process as you move through it. So the aim of your goal, it's good to know from the outset what you're trying to do. So we're trying to increase the number of patients who've had a heart attack, had PCI, had CABG, who are not just referred, but enrolled and participate. And so the goal is to increase that by 30%, right? So we want to do all the things we can, not just the automated referral, but the other components like care coordination, to try and achieve that increase by December 31st, 2022. So as you're thinking about how to do this, as Kathy Lee said, this is a team sport, right? So when you're thinking about your team, you need a lot of people. So you need your cardiac rehab champion, you need your cardiac care clinicians, your cardiac rehab clinicians, your care managers, your IT staff, your QI leaders, and don't forget the patients, right? So you want to think about how you have representation from all of those groups, and have them early on. Don't build it and then take it to someone and say, here's what we built that doesn't work for you. But to kind of create the team from the outset, and work together as a team. So some of the things that are really critical to success, as I think many of you know, right? So having strong executive support, having leadership at the top saying this is important to us and we're going to give you the resources and support you need to make it happen. Having clear ownership, having very clear and effective governance and decision making, and then last but not least, strong project management. Someone has to herd the cats, and there will be many cats.
Amy, before you or Kathy continue, executive leadership has an awful lot of priorities that they're juggling. And as you work with them over really an extended period to implement automatic referral, what did you do to keep them fully engaged over that time? It's easy to be committed at the start, but then other things come up. So what did you or your teams do to keep them committed and engaged so that you could have a successful outcome?
Amy, I'll follow you if you want to go first.
Yeah, sure. So I think what we tried to do was kind of have our North Star of this project will both improve patient care and in the no margin, no mission vein, actually increase revenue. And so when there were questions raised, basically reminding people the power of this project to achieve those two aims really allowed us to kind of keep driving forward.
So for us, again, it's always good to inform the leadership so that there are no surprises. And so because they hear other team members saying, well, this is happening and we weren't informed. So it's really important that everyone is informed at whatever level they can take. You know, sometimes people's cups are full and overflowing like they've been in the past 18 months. But it was important to share on maybe a quarterly basis so the leadership knew what the team was doing and how it was going to impact the hospital. So for us, it was about patient-centered care. It was best practice. It was going to impact revenue. And the biggest thing was we were also thinking about readmissions at the time. And so that was something that everyone had their ear up at the time was, oh, how can we impact readmissions? So, you know, there was actually a separate readmission silo work group going on at the same time. And we actually started to communicate and they're like, cardiac rehab, that helps with readmissions. I'm like, yeah, that's what the literature shows. And so now we have two work groups where leadership could see that benefit of what we were trying to do.
That's great. And I think those kind of clear goals really help drive things along. I think, you know, this mentions budget, right? And budget depends on how your IT resources are defined and whether you actually have to provide funding for IT resources or not. We actually don't. So our only budgetary considerations were actually for kind of the care coordination resources in terms of providing that human touch, if you will. But that may not always be the case. And so working with IT to figure out how you achieve the adequate resources, does that require budget or not? I think is important. And Kathy Lee, I don't know if you guys had any issues with that.
So what was really nice and similar, Amy, is that we didn't have quote unquote budget issues with IT. We got on, typically it's 6 to 8 months to be able to get on an IT rotation to develop a program like this. But because this was a quality metric for the healthcare system, it kind of brought us toward the top of the list. And that was really helpful. Probably the biggest cost to all of us was the personnel time that we invested in the development, implementation, and reassessment. But then in the outcome, it demonstrated increased revenue and fewer readmissions to the hospital. So the healthcare system kind of went, let's take a breath. So that was a good thing.
It's a great thing. So things you want to avoid. So common pitfalls, unclear project requirements. This can be just lack of clarity, or it can be different groups having different ideas because you never sat down and came to kind of a shared charter agreement of what you're trying to achieve. Poor management along the way, lack of communication and siloing of aspects of the project, not involving end users. We have an unfortunate history of asking attendings in academic medical centers who never touched the system, right? So they're not the ones placing the orders. If you ask them about the orders, they're going to give total misinformation. So working with the actual end user who's going to be touching the application is very important. And then lack of testing and kind of lack of thinking through all of the possibilities as you're doing the testing. It's very easy to test the obvious and in doing so, missing some things. Kathy,
Amy-
any other thoughts?
Yeah, just a couple, like when I think of failure, I could click a couple of different things on that slide. And, one of the things I'll just start with was we had very good management. I was very lucky for that. We had a project direction, but the communication was challenging in that we are practicing clinicians and we talk in clinician, but IT doesn't talk in that same language. And so having a nurse from the informatics team be on this was so critical. We'd be like, oh, well, we're going to get an order. And she's like, an order, like an order set. And we're like, no, a referral. And they're like, well, what's a referral? And so something as simple as the difference between an order set, and referral, it caused a lot of stumbling. So having that nurse from informatics was critical just to help have a common language. The quality testing, we did really great. And then if I told you the time range, we started with ICD-9s and then we switched to ICD-10s 1 month before the rollout. And so that quality testing, we had to go back to the table, and that was eye-opening and humbling, but that's what you do.
It is indeed. So we've talked a little bit about this in terms of key people to involve. So this is all about patients, right? We want to deliver better patient care. And so making sure that we are thinking about the experience for patients and where appropriate, kind of asking patient committees, patient representatives to make sure that this ends up being a good experience for them and achieves the desired goal. The cardiac rehab champion, as we said before, the QI specialists, for some groups, everything reporting and EHR build may be one group, or it may be two separate groups. So making sure that you have both reporting and IT analytics, if those are separate from kind of your main IT department, as they are for us, it's two separate groups. So we needed to make sure we had both. And as I said, the person who's actually going to be entering the order, not the person who has some imaginary idea but doesn't ever actually place the orders. Kathy Lee, any other thoughts on the people?
So just, because we had a lot of community hospitals rolled into our healthcare system, there were a lot of physicians that had admitting practices, but didn't necessarily weren't part of the project. They ended up being very key, and even now doing education with them as far as the benefit and the purpose of it. And it's not that they didn't order cardiac rehab, but they still were in the community office space, send a fax. And then, so again, the education was really important. Also letting them know how critical they were to the care of our patients. That was making them feel welcome, was really important in the process.
Absolutely. So once you have the right people gathered, you can start thinking about your design. And you guys have spent the time a couple modules ago now, back in module 3, thinking through what your workflows are. That's really kind of the foundation that you need to build this on, right? Is understanding how your current process works so you can figure out how you can, on top of that, incorporate in some automation. So just taking a step back for some terminology to make sure we're all on the same page. So order sets, we talk a lot about order sets in IT. So order sets are really just a group of standard kind of provider directives or instructions about the care of a patient. It's a very convenient tool for providers. You can think of it as a form of clinical decision support, where the system is saying, here are all the orders that I think for this patient are appropriate, or we would say appropriate for 80% of the patients, right? So that's our rule for what makes it in an order set. The clinician can take things off, can make tweaks, but it really streamlines the process and helps them get all the right orders in place. We, in general, do try and put things like this into the existing order set. So things that that the provider is already using, sneak this order in so that as they're ordering their existing order set, they're incorporating this automated order. So as you're thinking about the design, there are kind of 4 crucial factors to think through. Who are you going to be touching to try and make this order happen? When in the workflow are you going to do it? How are you going to put it in front of them? And where in the patient experience are you going to try and achieve this? So if we think about the who, identifying eligible patients, the advantage, if you will, of our billing system is that we have these very convenient CPT and ICD-10 codes associated with our patients, right? And that becomes a nice structure to tag this onto. So if someone went to the cath lab and had a PCI, I have a CPT code that tells me that. Same for their surgical procedures. If they're being seen for myocardial infarction, chronic stable angina, et cetera, they in general will have ICD-10 codes associated for the purposes of billing that I can look to and identify, hey, this is someone who it is appropriate for me to send. They have one of the diagnoses, they've had one of the procedures that makes them appropriate for cardiac rehab. Now, there are also exclusions, right? So you don't want to frustrate people by trying to refer someone who, for example, is on hospice. So you want to make sure that you not only get the patients who have the criteria, but you also exclude people who have comorbidities or conditions that would be contraindications to cardiac rehab, and eliminate redundancy, right? We don't want to see referral after referral for a single patient. Those types of things, as they happen in the provider workflow, that really kind of decreases the provider trust in the automation and makes them more likely to start opting out. So the more that we can make this as targeted as possible, the more successful that it's going to be. In terms of when, as I said, some places this is going to be easier to do at admission, and some places it's going to be easier to do at discharge. And so that's something that you will need to work through. We chose to do it at discharge, but there are other places that find for their workflow, for their system, it works better to do it at admission. For outpatients, it gets incorporated into some type of care encounter. As I said, we have struggled to find a good way to automate in the outpatient setting, and so we are focusing on inpatient for this project. Kathy Lee, other thoughts on this?
So yeah, the platform that we use in our healthcare system is the Millennium Cerner system, and it was set to do at admission. And so one of the things, the slide that you had up that had both the CPT and the ICD-10s, we use the ICD-10s to trigger, but we use kind of like a capture net for the CPT codes, because someone may have been admitted with a diagnosis that changed because they ended up needing a cath, or they needed to have a PCI, or they needed to have bypass, or even a valve replacement like a TAVI or TAVR. So having the CPT codes for us was a fail-safe to catch that eligible patient at discharge, where we couldn't change the ICD-10s to discharge.
Yeah, and before we leave the when question, there's a question in the chat from Stacy Greenway about, we recently included automatic referrals in our heart failure clinical pathway, but we're hearing pushback from rounding nurses that it should be ordered at their post-discharge appointment. What do you recommend in response to that?
So Amy, I'll take this one if that's okay. One of the things that Medicare, when you have someone with heart failure, they have to be stable a minimum of 6 weeks out from the hospital. So we worked with our heart failure nurse and the clinic to say that this would be done on their follow-up, and that we wouldn't trigger something automated for patients who have a heart failure diagnosis as part of our automatic referral process. It was going to be done at that outpatient follow-up is what we decided as a system.
Yeah, and we actually do, we don't have that exclusion, so we do all of it at discharge. And one of the issues for us is a lot of our patients are not necessarily seeing us for their post-discharge follow-up. So if we want to make sure that they get this referral, doing it during the acute care stay is the one chance that we know we have everyone before we send them out into the wilds to their kind of outpatient cardiologist who may be at a different facility. But it definitely is a conversation to have.
Yeah, thanks very much. And I should just note that we are planning a future affinity group that Dr. Hisham Scali will facilitate for us that focuses on the specific needs of heart failure patients, because they have some specific wrinkles related to cardiac rehab that are important and sometimes are not as well met as for other eligible patients. So, we'll let you all know when that's scheduled for, but that is an important topic that we recognize.
So how, one of the important things in the how is the opt-out, right? Because clinicians don't like to lose their ability to actually make decisions about care of the patient. So giving them the way to say, no, this patient is not appropriate. is important. That being said, you want to make sure that not everyone is opting out, that the opt-out usage is appropriate, and see, are there problems? Are we sending this for the wrong patients and people are having to routinely opt out for them, and we need to kind of tweak our definition of who should be getting the referral, so that providers aren't finding that they need to opt folks out. So again, the more that you align from the outset, but you will make mistakes. And so you want to make sure that you have tools in the system that allow care to continue and fix those mistakes, but also to recognize the mistakes are happening and improve the system as you go. It's really nice if there's an easy way for people to let you know when they see problems. So we have a lot of links in our system that let someone just click something and type a message to us. We call them cranky comments, and it's a great way to find out when the system is misbehaving so that we can fix it sooner rather than later. Kathy, any thoughts on this?
Yeah, one of the things in our design before implementation, we wanted to be able to track data, and the power form that we use had discrete fields on it. And so same thing with the opt-out form, it linked to a physician or a provider who used the opt-out. But if there was an eligible diagnosis, we were able to follow up to, and in some cases, just looking in the chart, you're like, oh my gosh, this person transferred to hospice. That makes sense. And then you'd go, oh, well, the physician just wanted a follow-up. Well, maybe our power form didn't capture that. And maybe we need to go back and look at the power form that's filled out that says, don't start cardiac rehab for 2 weeks, want a physician follow-up. So part of that, I think you mentioned it, Amy, was like that test retest of what's working, what's not working, and really hear from that end user at the bedside of, oh, well, I've done this many, and the reason why I'm opting out is because I want to see my patient. It's like, okay, you know what? Let's go back at our design and see how we can improve that to make sure we're capturing those patients.
Absolutely. So for community provider referrals, you can create a stop, right? So I run into this wall and I'm told, do you want to refer or not? For situations where you don't have kind of that order set to bake it into something they're already doing. If you're going to do this type of hard stop alert, make sure that you're firing it to the right people, right? So you don't want to ask the dermatologist if the patient should be going to cardiac rehab. It's going to drive them crazy. So you want to send this to cardiologists, internists. You want to send it during care encounters where it makes sense, not necessarily during care encounters where it might be more disruptive to them. And again, looking for the right patients as you're doing this. Any other thoughts on that aspect, Kathy Lee?
No, I agree with all of those, Amy. You want to make sure the right provider is involved, because you don't want to upset even the dermatologist.
Not that dermatologists don't care about the heart. I'm sure that they do. So which cardiac rehab program are you going to refer to? Now, it's entirely possible that this is a one-to-many, right? So I may have many programs that I need to go to. It may depend on the patient. You want to make sure that you're kind of thinking about your full patient population and how you serve their needs. So not only what are the things I can deliver, but if I have a patient who is going to leave me and go to Florida, how am I going to handle that? Or am I going to handle it? I'm going to say that's not my problem, or is that something I'm going to try and take on? We do know that patient convenience is a major factor in participation. So we do want to make sure that this gets factored in as we're trying to make this work for patients in order to succeed. Kathy Lee, other thoughts on that?
So one of the things we did with when we do the contact, we built into our communication power form 50 different cardiac rehab programs that were in the region. At the time when we initiated, we only had one cardiac rehab program. Well, if you think of traffic as a barrier to come to cardiac rehab, it's a barrier to come to cardiac rehab. And so we wanted to do that convenience for the patients. And they were like, really? You're going to give me information about an outside program? And we're like, absolutely. We're really about making sure that you've got continuity of care. And the patients were just so excited to hear that we were willing to make sure we could find a cardiac rehab program closer to them, whether they worked or where they lived, and they got buy-in. And we actually heard that they would go back to their cardiologist and say, they referred me outside of the system for convenience. What's that? So it was really a win-win.
That's really awesome. So once you've gone through all of that, now you figured out everything you need to know about your design, You figured out how to choose your patients, when you're going to do things, how it's going to appear to providers, how they're going to opt out, where you're going to send the patients. So how are you going to test it? And testing is never perfect. You are always going to find that you miss things, and things will evolve over time. But the goal is to catch as much as possible before you put this in a place where it actually touches your providers and patients. So there are several phases to this. First thing is, of course, to figure out what you're going to do. Then you've got kind of your initial behind the scenes bench testing. Then you've got pilot testing, and then kind of a system-wide testing. Ideally, all before you implement. So if you're thinking about your testing plan, how many phases do you need? What is the goal of each phase? And what are kind of the criteria to make sure that you've completed that phase? Who do you need involved in it? How are you going to track and monitor how you're doing? How are you going to get feedback from people involved, particularly when you're in things like pilot phase and you have some end users involved? How are you going to give them the opportunity to let you know when there are problems? And how are you going to know when you're ready to move on to the next phase? And I think there's a lot of information in your implementation guide, kind of some more details on this. So bench testing, this is really making sure that in kind of a non-production environment, something that doesn't at all involve patient care, that you are actually identifying the right eligible patients for referral. And you want to do kind of, we think about positive and negative testing, right? So I want to make sure that if someone's eligible, I identify them. And if someone's not eligible, I don't identify them. You want to make sure that the referrals are going to the right place. So not just that I get the order, but it goes to, say, a work queue, the right work queue, so that someone will actually work it. And any other requirements that you have and kind of how you get that patient scheduled, you want to make sure that all of those dominoes are falling technically so that the tools are in place for this to work for patients. Without doing this type of testing, you might be okay, you might not. And so this is a really important way to make sure that you don't miss any kind of details in the build. So I think, Steve, that we'll hand it over to you now.
Yes, can we go back to the last slide for just a second, if that's possible, Teresa? So I wanted to ask both of you before we move into the formal Q&A session, just so that people understand that even experts like yourselves, it doesn't work perfectly the first time through, or even the second or third time through. So how many glitches, how many fixes did you need to make from the time that you did your first bench test to the time you felt comfortable, starting to use this on real patients?
I don't even know if I could give you a list of how many times that we did test, retest, and how many glitches. It's you kind of forget them after a while once it gets up and running and you're thinking, oh, this was wonderful, but yet you knew there was pain the 18 months before. I will bring up a glitch that we didn't think of. So we developed a multi, I think Amy called it a queue, but ours is called the multi-patient task list. And as soon as the doctor in the hospital, any of the hospitals, click sign, it comes real time to us. And we were calling the patients and they just came out of the cath lab. And so we had to, it wasn't something, we were like, oh my God, we're so efficient now. And the patient's wife would answer the phone and go, hello. And it was like, okay, well, let's step back. That's not something we didn't think we would be so efficient to cause a different kind of glitch. So, it's always nice to talk to family members, but so we then step back and set up another way instead of, because our orders are done at admission, we said, let's wait this many days before we call. And since then, it's been wonderful. But it was like a couple of those embarrassing moments,
There are always embarrassing moments. And I think the other thing to keep in mind is no matter how good a job you do at this, the EHR to some degree is a living, breathing thing. It evolves over time. And so you will introduce things that aren't intended to touch this at all, that do touch it, right? So you'll have something that's working beautifully, and then someone makes a change somewhere else, and suddenly the referrals are going to the wrong place. And so there's the work that you do up front to make sure that you do the build right, but there's also the monitoring that you want to do once you're live to make sure that it's continuing to work as intended. We have had a couple of instances where things were great for a period of time and then suddenly something got changed, wasn't changed by anyone in this team, but it disrupted this workflow. And so the more that you have a way to see that happening early on, the better off.
And just one additional thing, as we're having a horrible storm right around me, I forgot about EMR downtime. So you can design a wonderful automatic referral system, but if the cloud goes down, the system servers go down, you have to have a backup.
All right, thanks very much. These are great practical insights of the sort that we know are benefiting the people that are on the call. We would like everyone that is participating to take a minute and reflect on what you've heard up to this point and enter into the chat a particular insight, could be 2 if you can't, or 3 if you can't decide on which one is the best, but just an insight that you've gained during the conversation today that you think will benefit you as you work with your team to implement automatic referral. So go ahead. We know that it'll take a few minutes for you to crystallize your thoughts and put it into the chat. But if you could just share those insights, that would be fabulous. We like to see what is what really resonates with people, and then we can make sure that we call attention to those insights in the peer action groups, and even perhaps highlight them more in future editions of the slides or the implementation guide.
And Steve, if you don't mind, I am going to share that even with all of our glitches and challenges and barriers, we are now almost consistently over 70% referral rate with this automated system. And that would never have happened if we didn't take the big plunge to make this work as a healthcare system.
Right. Thanks very much. And I think that, there's an expectation management issue to all of this. And if you're very clear up front with all of the people that you're working with, that, we are going to need to fix things, and it's not going to be perfect right out of the box. And we really want to work with you to identify quickly and make the changes to make it better. If you go in with that approach as a partnership, as opposed to we're going to do it the right way, and if we don't, then somebody hasn't done their job, it's gonna be received much better. There are some questions coming into the chat, and I want to get to at least some of these. How important is it to educate the end users who will be using the order sets?
I think that is, once you have the process in place, to me, I think of them as stakeholders, because they're the ones that are actually counting the number of clicks that need to be done to fill out the forms and sign off or do the opt-out. So it was really important for us we did full shift education. We had marketing help us. And so making sure that there's buy-in and understanding of the process. And I will say some of our younger physicians that came on, because they're so used to quick, whereas some of the older clinicians that are practicing, it was a little bit easier for them to know that they had step by step, whereas our newer physicians, they're like, okay, well, it takes me this many seconds to fill it out. And I'm going, okay, you're describing it as seconds. This is good. So yeah, very important, Steve.
Yeah, and I think for us, it was less about the technical aspects. The order sets are order sets. They're very straightforward. It's actually no work for them or minimal work for them. It's one click in general. But selling them on the concept. So the value of cardiac rehab, I think, is really where you get the value and the win. That, is part of that care coordination, part of them having the conversation with the patient instead of just clicking the box, and making them think twice before they opt someone out, thinking, oh, I don't want to talk to someone about this, they're not going to go, kind of thing. So willing hearts and minds, I think, is critical.
I think that needs to be the motto, Amy.
All right, thanks. I'm sensitive to time. Please continue to add insights or add questions. We'll be saying a little bit more about opportunities to answer those questions. We recognize that there are wrinkles associated with working in Epic, Cerner, Meditech. And so one of the things that we're doing is we're setting up some sessions that will focus on those wrinkles in particular, in those, particular EMRs. We're working on one for Cerner as well. We don't have the details finalized for that, but we just wanted to alert you to 2 sessions that are exclusively focused on Q&A. One scheduled for the 14th and one scheduled for the 22nd. So the links to register for those are here. You can answer, or you can submit questions that you'd like the panelists to answer. When you register, we'll also have an opportunity for people to be asking questions during the event as well. It's going to take a while for you even to figure out the things that you need to know answers to. So we want to give you a chance to get started into the process and then schedule a Q&A sessions in about a month from right now. So we want to alert you to those things and then add a couple of additional comments as we wrap up this morning or this afternoon. I guess if it's morning, you might be, maybe it's still morning in Hawaii or parts of Alaska. Action steps. Continue working on your action plan. Think through what you need to do to implement automatic referral. We want you to get started with this so that you can see the areas that you're going to need help with so that we can support you with that. And then in just a week and a half or so, we want you to participate in your peer action group so you can discuss the progress that you're making, hear the progress that your other peers are making, share challenges, vent a little bit if you have to, but then find solutions. So that will be really what we want to accomplish in those peer action groups. And then the implementation guide has a lot of very practical advice on things that you can be doing as you start planning for your automatic referral. So we really encourage you to look at that, to share it with other team members as you get going in the implementation process. As a reminder, our next training module is September 30th. You can register for that already, and that's really the focus is on groundwork for care coordination. We're kind of going back and forth between automatic referral and care coordination because we know that it's going to take a little time to get going with automatic referral. So we want to give you a couple of months before we do the second module on automatic referral. We want to introduce care coordination, give you a little time to get going before we return to that topic in module 8. So that's what's coming up on September 30th and will be an excellent way to finish off the month of September. And then as we wrap up, we always look at your responses to the feedback questions at the end. So please just take a few seconds and answer those questions as you wrap up today. I want to thank Amy and Kathy Lee for great insights today. And really for their persistence in working to get automatic referral, not just implemented, but implemented and working so that it benefits their patients and their program. So thank you both very much. Thank all of you in the audience for good questions and comments. And we hope you have an excellent rest of your afternoon.